Alright, so now that we've gotten the basics of anatomy out of the way, let's jump into the good stuff here. So we'll start out with Chapter 2, Spine and Upper Extremity. So first lecture here, we're just going to go over the osteology of the spine. So, basic overview. The spine is composed of stacks of vertebrae forming the vertebral column. So each one of these is a single vertebrae, and we'll go through the structure of these in more detail in a few slides. And so it's really just all of these vertebrae stacked together. That's what forms the vertebral column, which equals the spine. So there's 5 sections in the spine. There's 7 in the cervical region, which is this part here, which is in your neck. Next, there's the thoracic section, which is here, which is 12 vertebrae, and these are the vertebrae that articulate with the ribs to help form the thoracic cage or your rib cage. Then next down is the lumbar vertebrae, which is right here, and there's 5 of these, and that's what's formed your lower back. This is often the cause of low back pain, one of the most frequent causes for someone to go to the doctor. Then there's the sacrum, which is the sacrum, even though it's one bone, it's technically 5 fused vertebrae together. Then lastly, there's this little tailbone here, which is the coccyx, which is 5 fused vertebrae as well. So even though they're single bones or single structures, they're actually fused vertebrae. Next, the curvature of the spine, which is very important for its function of bearing weight and helping us have our upright posture. So it has this S shape to it like this, okay? And this is the result of 2 types of curvature, the primary curvature and the secondary curvature. Let's talk about the primary first. So what does primary mean? Easy to remember, it's intrauterine, which means it forms during embryonic development. And it's a concave anterior shape. So if we look anterior like this, posterior like this, it's going to be shaped like this. This is concave anterior. This is the shapes of the thoracic and the sacral section. So if we look here, thoracic has that concave anterior, and then you have the sacral region, which also has that. So these are the 2 primary curvatures of the spine. So in utero, the entire spine is this shape, is this concave anterior shape. After birth, the spine takes the secondary curvature shapes, which we'll talk about in a second, but what retains this primary curvature is the thoracic and sacral spines. All right, so now we have the secondary curvatures, which, as I was talking about on the previous slide, these develop after birth, okay? And they're concave posterior. So what does that mean? If we have it like this, if this is anterior and posterior, this is concave posterior. And this is the shapes of the fully developed cervical and lumbar sections. So you can see they have that concave posterior shape. Now, as I said, in development, you have this concave anterior shape, and then what ends up happening is this first you develop the cervical section. This develops at 6 months when the baby is able to lift the head up. So the baby lifts the head up, that gives it the concave posterior shape, giving you that secondary curvature. Then the lumbar section develops when the infant assumes the upright position at 1 year old, okay? So then this section will develop at 1 year old. So it's easy to remember. The cervical spine is what helps you hold your neck up, helps you move your neck. It develops when the baby lifts the head up, which is around 6 months. Then the lumbar section, you can think of it, it's lower, it's more responsible for, locomotion, moving. So that's when the baby assumes its upright position at 1 year old. Now, what do these curvatures do? They function to maintain our upright posture by evenly displacing the weight of the body throughout the S shape of the vertebral column. So if you notice, the spine is not just one straight pull, okay, and that's by design, is it helps evenly distribute the weight throughout this S-shaped, okay? And so it's not like one vertebrae at the bottom here is bearing the weight, because if you had just one column, the weight is going to be bore by the lowest point. So it helps take the load off of really this L5 and sacral region and help evenly displace it throughout the spine. That's why it has that S shape. All right, so we're going to use this model of a vertebra to show its components. First, we have the vertebral body, which is this thick oval segment of the vertebra right here. And this is what the intervertebral discs separate, which provide cushion, weight bearing, and movement of the vertebral column. The vertebral body is also a site of hematopoiesis in adults. Next, we have the pedicles, which project posterior lateral like this. We'll show this with the pen here. And that's these structures right here, the pedicle on each side. Then you have the lamina, which begin posteriorly at the pedicles here and here. They continue posteriorly like this and medially, and then join at the base of this spinous process. So this is the lamina right here, these two structures. And then you have the spinous process, which is a bony prominence that sticks out or projects posteriorly. Then you have the transverse processes, which are these structures here and here. And these project laterally out from the junction of the pedicles and the lamina. So here's the junction right here of the pedicle and the lamina, and then here's the transverse process projecting out laterally from it. The vertebral foramen is this hole right here, and this is formed by the posterior aspect of the vertebral body, so you can see that here. And then the pedicles, which project out posterior lateral like this, and then the lamina like this. So the whole thing. So vertebral body, pedicle, lamina. Lamina, pedicle, vertebral body. That's what forms the vertebral foramen. Now the contents of the foramen are the spinal cord, which runs directly through. Then you have the meninges, which are those connective tissue layers that surround the brain and spinal cord. Those are running through. You have some vertebral vessels, some adipose tissue, and then the spinal roots, which are coming off the spinal cord at each level. The vertebral canal is basically all of the vertebral foramen stacked together. So you stick this through here, it's one vertebral foramen on top of the other. And then the vertebral arch, which is this structure right here, is formed by the pedicles and the lamina. So you're not including the vertebral body. It's this arch right here. So pedicle, lamina, lamina, pedicle. So we're going to go to this posterior lateral view of the skeleton model to give you a good view of the articulating processes. So each vertebrae has a superior and an inferior articulating process, and these project from the junction of the lamina with the pedicle. So the pedicle's behind here, and you have the superior articulating process, which projects this way, and then the inferior articulating process, which projects inferiorly, both from the same junction. And they form what's called the intervertebral facet joints, also known as the zygapophyseal joints. And these joints are what gives the vertebrae this shingling look to them. Now, what forms a facet joint specifically? So you have, let's take this facet joint here, for example. So you have the superior articulating process of the inferior vertebra articulates with the inferior articulating process of the superior vertebra, and that's what forms the facet joint here. So we're going to give you this zoomed in posterior look to give you a good view of the pars interarticularis. Now what is this? This is a bony part of the vertebrae that is at the junction of the pedicle and the lamina. So right here. And what it is between the superior and inferior articulating processes. So it's a very specific location. It's at that junction, and then it's between the superior and inferior articulating processes. So it's right here in this part here. And this is a part that is susceptible to fractures, which we'll talk about in the clinical pearls section. So just to show you a radiograph of this pars, on a lumbar spine, the pars is referred to as the neck of a Scotty dog image. So it's which is formed by the outline of surrounding vertebral structure. So if we look here on this x-ray, this is really an oblique or posterior lateral view of the lumbar spine. And so here's the head of the dog that I'm tracing here. Then here's the body of it. Here's its hind legs here, and then its front legs here. And so what the pars is thought of is this neck here. All right, so now we're going to talk about the unique features of the cervical, the thoracic, and the lumbar spine. And first we'll start with the cervical. And the C1 and C2 vertebrae are very unique. They have unique structures that help them with their unique functions. And so we'll start with C1. So C1, the very first vertebrae, it's also called the atlas. These are used interchangeably. Atlas, it refers to a figure in Greek mythology. And there's a famous image of him bearing the weight of the world, and so that's where that comes from, because it's thought of as the C1 vertebrae is bearing the weight of the skull. So that's why it's called the atlas. So C1 vertebrae, it articulates with the occipital condyles of the occipital bone. The occipital bone is a plate-like bone that forms the posterior inferior region of your skull, where the cervical spine articulates with the skull. And this articulation point is called the atlanto-occipital joint, and this is what allows the head to nod up and down. It has no vertebral body, so that's what's unique about this vertebrae. So if you remember in the skeleton model, we were talking about the standard vertebrae. So you have your vertebral body, then you have your pedicles, then you have your lamina, your spinous processes. So here there's no vertebral body. So if you look here, there's no vertebral body. It's a ring-like structure. So it still has pedicles. These are your pedicles here and here. Then it has your lamina like this, and then you have the little spinous process here. But you don't have this vertebral body. And what happens is this ring-like structure, it forms anterior arches, which is here. You can see it labeled in your diagram here. And then posterior arch here. So again, forms your anterior arch here, posterior arch here, and then if you divide it in half, these are called your lateral masses. Okay, so 2 lateral masses. 2 arches, 2 lateral masses. Now, let's talk about the anterior arch. So it has a convex shape to it like this, okay? And at its center, it has, at its anterior surface, it has the anterior tubercle, which is right here. And this serves as the attachment for the longest colli muscles, which are muscles in the anterior portion of the spine. We'll get more into those into the head and neck lectures in Chapter 7. It's also the attachment point of the anterior longitudinal ligament, which is a thick fibrous ligament that runs down the anterior surface of all the vertebrae in the spine. Okay. Then you have the posterior surface of the anterior arch. So we're still talking about the anterior arch. It's a concave shape, and it contains at its center an oval facet, which is right here. You can see this little oval shaped part here. It's an oval facet for articulation with the dens, also known as the odontoid process. As you'll see in anatomy, many things have multiple names. It can get very annoying as a student when you're trying to learn this for the first time. We will try to point out the really high yield and common names that are used for every structure we can think of, okay? So these are 2 that are used very commonly interchangeably. It's the same structure, the dens or the odontoid. And we'll point it out when we talk about C2 in a second here, of the axis. So the C2 is also called the axis. And when we explain this, it'll make much more sense because you need to know what the dens is in order to fully understand this structure. The dens is really, it's a superior projection that articulates here. We'll show you in a second. So the posterior arch, this part here, it contains the posterior tubercle, which is this part here, which gives rise to the nuchal ligament, which is a big fan-like ligament that runs down, interconnecting the spinous processes. Now let's talk about these lateral masses here, okay? So they have these are what have the superior and inferior articulating facets. So you have your superior facet here. This is what receives those occipital condyles. So these are what are responsible for articulating with the head, okay? And then the inferior facets, which are on the inferior surface of this, they articulate with the axis, or C2, and they allow rotational movements of the head. So that articulation between C1 and C2, that allows rotation, okay? Then you have large transverse processes here, okay, here and here on each side, and they project laterally from the lateral masses. So these are your lateral masses, and then you have your TPs here and here, okay? Now, within the transverse processes, you'll notice that there's these foramen here, okay? These are your transverse foramen, and these are what carry the vertebral arteries before they enter the skull. So the vertebral arteries come off the subclavian artery, which is an artery in the thorax, and they ascend up through the neck, and the reason they're called vertebral arteries is they ascend through these transverse foramina of the cervical vertebrae, okay, and it helps protect them as they ascend up, and then these end up joining together at the base of the skull, and then they go on to help supply the brainstem and the brain, and we won't get into the rest of that since that's more neuroanatomy. Now, one thing one thing that's kind of clinical or surgically relevant is if someone's operating on the cervical spine, you better be sure that they're going to be careful that they don't pierce the vertebral arteries if they're operating on the cervical vertebrae. That's something that is definitely in every spine surgeon's mind when they're doing that. Now, let's talk about a clinical correlate here. Jefferson fracture. So what is a Jefferson fracture? It's a fracture of the anterior and posterior arches in at least one or more places. So here's an axial view of the C1. So here's axial. This is an axial CT scan of C1. Okay. Mechanisms of injury. Axial loading of the head on the spine, and these can be very serious. They, for obvious reasons, they can damage the spinal cord. This is definitely an injury you don't just go home with. Okay, this is something that needs to be treated urgently. And also another way it can happen is if you have direct impact to the posterior aspect of the cervical spine up towards the head. How these will present: definitely neck pain. Not often they don't have neurological symptoms yet. That's something that but that's something that can develop. It's not like they never present with neurological symptoms. It's just something, don't be surprised if you see this in a test question or if you're on a rotation and you see a patient that has one of these and they're not totally paralyzed. Don't be too surprised by that, okay? Fractures, they can result in damage to the arteries, mainly those vertebral arteries in the neck, but not just those, also the carotids. They can potentially cause Horner syndrome, which is, PAM is the way you can remember this, and Horner syndrome, that is something that will come up in many clinical correlates. So ptosis, okay, that's one. That's like droopy eyelids, so they can't lift their eyelids. Anhidrosis, which means they don't sweat. And then you have meiosis, okay, which is constriction of your pupils, okay? And these are all sympathetic nervous system, okay? And what happens is, really, the long and the short of it is, we'll get into this in more detail later, is that you cut off sympathetic input into structures in the head and neck, and that's what causes. So you lose your sympathetic innervation, which helps lift your eyelid. You lose your sympathetic innervation that helps produce sweat, so you don't sweat, you have dry skin. And then you lose your sympathetic innervation, which would help dilate your pupils, so you have very constricted pupils, okay? That's what that is. You have ataxia, which is basically, you have trouble balancing while you walk, inability to sense pain or temperature, okay? And again, that's because of damaging vessels in this region that really go to the brain and affect other neurological structures. How do you diagnose it? X-ray and really CT scan is the best, and that's what we've shown you here. So if you look at these arrows here, this is the anterior arch being fractured here in these two places. You have the posterior arch fractured in this place here. And then what we'll show you here is, this is the dens coming up from C2, okay? So if you're looking, this is like looking down through, if you're looking down through here, C2 would be just below this. This is that dens or odontide process, which comes up through and articulates with this anterior arch here, okay? So what's the treatment? If the patient's stable, you put them in a collar immobilization. So that's just that, those thick neck collars you'll see people have. If it's unstable, you got to do surgical fixation, which means you go in and you fix the fracture surgically, okay? So now, how do you determine if it's stable? Partially, it's by the integrity of the transverse ligament. So we haven't gone over that yet because we're going to do the ligaments in a few slides here. But what I'll show you here is the transverse ligament goes across like this, okay? It connects the lateral masses. So you have a lateral mass here and here, okay? And then you have this transverse ligament, which comes across here, and it wraps around the dens, the odentate process, okay? And it helps, keep this whole atlas C1 structure intact, okay? So one way you can determine that is, if you look on an axial CT, is the atlantodental interval, ADI, is measured to be larger than 3 millimeters. Now, what in the world does that mean? So here's the dens here. Here's the anterior arch here. So this distance right here, see this space right here? This space, if that is greater than 3 millimeters, and so you can measure that on the CT, if it's greater than 3 millimeters, that usually means that the transverse ligament is torn, okay? So this is torn because what happens is this transverse ligament helps push this odontide process, or dens, up against this anterior arch. So think about it, if you tear this ligament because the injury is so bad, you lose this support, and you tear it, then this is able to travel this way, okay? It's able to travel posterior, and then you make this interval larger, okay, than 3 millimeters. And then the fracture is considered unstable. So the C2 vertebrae, also known as the axis, okay, because you consider an axis of rotation, the rotational base of the atlas and the skull, hence the axis, okay? So unlike C1, C2 has a vertebral body, and it also has a prominent projection that we've been talking about a lot here, which is called the dens. So this is a good picture. This is a posterior view, kind of posterior superior view of the C2 vertebrae, and you can see this dens is this structure that it projects superiorly, okay? Now it has an oval circular facet on its anterior surface. So we're looking posteriorly. Here it is right here. This is a sagittal view or a lateral view. Okay? So here's that articular surface, okay, which if you look at that axial of C1 like this, okay, so we have the transverse processes like this, You have your anterior arch, posterior arch, that little tubercle here, and then you have the dens coming up here. This is what articulates with that anterior arch of C1. Okay? Now, this allows for the C1, C2 rotation. So this process, it helps stabilize that C1, C2 joint and helps enable the rotation. It's also the primary horizontal stabilizer of the atlantoaxial joint, which is a fancy word for the C1, C2 joint. Okay. Now, just to point out the rest of the structures with C2, you have this superior articulating surfaces or facets. You have them on the inferior surface. You have the transverse processes here. You have that transverse foramen here, okay, on both sides. You have a spinous process. Again, you have pedicles like this, and then you have lamina that come in like this to form the base of the spinous processes. This is a lateral view of it as well, and you can see the spinous process projecting out posteriorly here, okay, just to be thorough. And then also this gives you a good view of the inferior articular processes as well, and then superior. Okay. All right, so now a Hangman's fracture. It's a fracture of both the pedicles or the pars interarticularis of the C2 vertebrae. So here's the pedicles like this. So it would be fractures here and here, or of the pars, which is the structure between the superior and inferior articular processes at the junction of the pedicles and the lamina. So it would be in here and here, okay? So between those two. What are the causes of these? Falls, especially in the elderly. Motor vehicle accidents due to hyperextension of the neck, so putting a lot of pressure on these regions of the vertebrae, and then also axial loading onto the C2 vertebrae. Okay, so again, don't dive into a shallow. Your mother was right. Don't dive into a shallow area of a swimming pool or a creek or a lake or whatever. So the mechanism of injury. So how do these happen? So here's the causes. It's a sudden, very forceful hyperextension of the head just under the chin that occurs mainly with deceleration injuries, okay? Now, the reason these are called Hangman fractures is because they were thought to be also when people used to be hanged in, older days, is thought to be responsible for killing people. Is what happens is that when when the board below someone gives out, the person is hyperextended, their neck is hyperextended, it fractures this, and then the bone goes in and pierces the spinal cord and then pierces the descending tracts that go down to, help drive inspiration and respiration, okay, down to that eventually would go to the phrenic nerve, and then it cuts off your ability to breathe, and then that's what kills you. So that is where the origin of this name comes from, Hangman's fracture. Now, what do you do for these now? How do you treat them? If someone comes in, is you give them a neck collar or surgery. It just depends on the stability, their neurological function, what else is going on with them. So these are usually the two treatment options. So now the rest of the cervical vertebrae, C3 to C7. So these vertebral bodies have what's called uncinate processes. So if we look at an anterior view here of a cervical vertebral body, is they have these superior projections that hook out on either end, okay? And then you have your disc in here, and then you have your vertebral body like this of the superior vertebrae, okay? And then along with the intervertebral discs, these uncinate processes, what they do is they prevent translation off the vertebrae. So they help prevent translation this way. They help because your neck has a lot of movement, and so you do not want to have instability in your neck for plain function. And then also, if you eventually, as we'll talk about in the clinical pearls section, is you end up getting significant pain and disability eventually, and even neurological deficits if the cervical spine develops significant instability. So it prevents that translation off. And it also limits lateral flexion. So it's good to have some lateral flexion, but you don't want to have it completely inhibited or completely uninhibited, excuse me. And then also note is the spinous processes are short and they're bifid. Now this diagram doesn't show you that very well. What bifid means is they have like a two prong like projections, two bony projections that kind of look like two prongs sticking out. And these are attachments for muscles, ligaments, and they just help you, you know, more surface area for attachment, and those are unique to the cervical vertebrae. The superior and inferior articular facets are flat and oval shaped, and you can see that here, and they're located at the junction of the pedicle and the lamina. The transverse processes, as we described earlier, they contain this transverse foramen, and this is where the vertebral artery, vertebral vein, and then plexus of sympathetic nerves all travel in here. Okay, and it's just to have bony protection for these structures. Now, the vertebral prominence. So if we go, so one way you can if you're looking at an X-ray or a diagram of a cervical spine, is you always look for, honestly it's easier to usually to look for your C2 because it's very prominent spinous process in comparison to your C1 here. So you know that this is C2, okay, and you just count. A lot of looking at vertebrae, it's just counting, okay. So C2, C3, C4, C5, C6, and then C7, okay. So this is our C7 here. Now, the vertebral prominence is a distinctive and long spinous process of the C7 vertebrae. So you can see that here, very long, prominent, and it's the first palpable spinous process. So if you were to have a patient in front of you, and you're looking to palpate spinous processes, C1 through 6, you're not going to be able to palpate any of those spinous processes. The first one you'll be able to is C7. Okay. Now, we'll briefly talk about the thoracic spine. We'll talk about this in a little more detail in the thorax in Chapter 3 and talk about how it functions with the thoracic cage. But here we'll just give you a rundown of the nuts and bolts structure. So it's a heart-shaped vertebral body. That's not a super high-yield fact, but some people, you know, it's one way you can distinguish it. So if you look at it here, some people say that's heart-shaped. And then on both sides you have two costal facets. Okay, so that's here and here, and costal is another word for rib, and so these are articulation points for the ribs. So you can see the ribs here articulating with the thoracic vertebrae. This is what forms that junction. Okay, now they're near the base of the pedicle, which is right here. So that's one of them. So you have the pedicle sticking out here. Then the other one is anterior to the inferior vertebral notch. So what I'll show you here is that this part here is the inferior vertebral notch, which is formed by the pedicle and then the vertebral body here. Okay. Then you have the transverse processes, which they have a terminal concave surface, which is unique to these thoracic vertebrae, and they articulate with the tubercles of the rib. Okay, you can see these articulation point here. And lastly, just to show you, this is a posterior view, and you can see these ribs coming out, and this is where they're articulating here. So this is a good showing here of this. So it's articulating. So the rib, it extends out from these facets directly on the vertebral body, and then it also articulates here as well with this. So a rib has two articulation points with the vertebrae, directly on the vertebral body, and then it also articulates on the transverse process. The lumbar spine, so these are the bodies are kidney shaped, if you look at here. And then the vertebral complex. So again, we'll start with counting, okay? So here's your sacrum, here's your L5, okay? And then you just count up. So if you're ever looking at a lateral view or sagittal view of the lumbar spine and you're trying to figure out what vertebral body you want to be looking at, or maybe there's a disc herniation or something else you want to look at, it's just counting again. So you look at the sacrum, then you have L5, L4, L3, L2, and L1. So here's L1. Here's T12, okay? And then this is what's called the vertebral complex, okay? So why in the world do we care about this? Well, it's a transition point between the T12 and L1 vertebrae, which essentially means it's a transition between the thoracic and lumbar vertebrae. And what's really interesting anatomically and clinically is it's a change in curvature, okay? So we have this concave anterior curvature, okay, in the thoracic area, and then you switch at this junction here to a concave posterior curvature. So this change in curvature is what gives you instability at this point, because you're changing the way it's, you know, it's not consistent, okay? And so what this dramatic change in curvature does is it makes this area of the spine very susceptible to vertebral column body fractures, okay? And it's actually the most common site of a vertebral column body fracture, and that's because of this instability. There's not as there's not as much support because of this change in curvature. So it's an area where weight is getting redistributed. All right, and that concludes our discussion of the osteology of the spine.